To begin with, I would like to thank the organizers of Frontiers in Living Disease for giving me this opportunity to sum up these great talks. So I'll start with Dr. Punita's talk. She started the talk with goals of defining care and stressed on the importance of psychological, financial, and family distress involved, and the poor quality of life that is associated with all these patients who have cirrhosis. She talked about integrating palliative care early and not to leave it too late, as the number of referrals we're getting is too late. She stressed on the importance of surrogate decision markers in the family and the importance of early discussions with the familiar physicians whom the patients have interacted with. Uh, uh, and she did show data on how such discussions actually decrease anxiety. She talked about best and worst case scenarios in the video and the importance of communication skills and overcoming all these barriers which are associated with palliative care. The all these summed up, I think palliative care in liver has taken off, and it needs great detail and attention to be given to palliative care aspects as well. Coming to the talk by Dr. Kaushal on disease modifying therapy, he talked about the stages of stages the patients undergo as cirrhotics, and the intervention points where we can actually intervene to turn around the disease. Talked about DAAs, which could modify HCV, and one fourth of all the patients who had low MELD score could be delisted off when you provide therapy with DAAs. He talked about targeting portal hypertension with beta blockers and bacterial translocation with treatment with norfloxacin to prevent SBP. He talked about probiotics as well, which lead to lower incidence of admissions with hepatic encephalopathy. Uh, he talked about novel drugs, particularly low molecular weight heparin, which reduces microthrombi and congestion in the small bowel and congestion in general in the GI system, leading to decreased bacterial translocation. Uh, he talked about vitamin E, which modifies NASH, and albumin. We all have used albumin, and we know about how important it is for any liver unit. There was a discussion on statins, which were used to prevent rebleeds, and they have, particularly in HCV patients, decreased mortality on the long-term basis. He talked about targeting malnutrition and improving the nutrition status of patients with sarcopenia. Certainly, the talk gave us the impression that there's more hope in disease modifying therapy, which would lead to further better outcomes in patients being treated with cirrhotics. Coming lastly to Dr. Shalin's talk for liver transplantation on alcoholic hepatitis. The talk began with definition of alcoholic hepatitis and prognosis associated with matrix discriminant factors and the benefit versus harm of steroids. He did show enough data to show that early liver transplantation has good results in alcoholic hepatitis. He showed a study where which was published in 2018, wherein the results of patients transplanted with bland cirrhosis versus patients being transplanted with severe alcoholic hepatitis were not significantly different. And in patients with good psychosocial support, even the long-term results plus the rate of recidivism was well below 20%, which is the same as we can see with bland cirrhosis as well. So he did stress on selection of a particular set of patients with good family support and social background to give better results with for patients being treated with alcoholic hepatitis. So to set the bar right, I think he talked about having objective criteria for selecting these patients, and if selected well, the results for patients being transplanted early for alcoholic hepatitis is as good as any other etiology being transplanted. So I'd like to conclude by saying uh, about all these three talks. Uh, they were wonderful, and all these things need to be taken into consideration in a further practice. Thank you.